These are examples of BPSDs overall. Again, just a few set, not all of them, not all inclusive, but agitation, aggression, paranoia. So thinking that that someone's stealing from them. Theft is the most common one. Infidelity, phantom boarder, thinking someone is living with you in the home when they're not. And poisoning, which is very difficult to treat. Delusions, hallucinations, visual and auditory, wandering, anxiety, depression, perseveration, insomnia, apathy, anxiety, and depression. So extremely variable. Some could have one, some could have a few, and very different response to treatment and medication. So that's very important to note, and I'll go into that in detail soon. What factors do we look at when we look at BPSD? Really, when you look at the status quo of people assessing those with behaviors, they focus on the patient themselves, and that's fine, that's one factor. So you look at their unmet needs, you look at their medical issues, their sensory deficits, their life story, their hobbies, to try and remedy those behaviors. But I would encourage you to look at other factors as well that influence said behaviors, in particular the environment. Is it overstimulating? Is it understimulating? Is it unsafe? Is there lack of activity and lack of routines? And also from the caregiver as well. So is there stress and burden and caregiver burnout? Is there lack of awareness and communication? What is their expectations for said behavior, right? So Dr. Fahad Al-Wahabi did a fantastic job explaining the social dynamics of this a few minutes before me on this aspect and topic. So what is the approach overall? Well, per evidence, there's an approach called DICE, which stands for Describe, Investigate, Create, and Evaluate. So a holistic method of looking at behaviors and dealing with them. So describe, think about the ABC. So A stands for antecedent, what happened before the behavior. Don't just listen to the healthcare provider saying, oh, they were agitated or aggressive. Think what happened before they had that behavior that caused it. Then the behavior itself, describe it in more detail. Don't just say they were upset or angry or they hit a nurse. What happened exactly? And then see for consequence, what was the aftermath of said behavior? After that, you want to investigate and see how to remedy said behavior and create a plan for that with the three factors. And lastly, evaluate your plan and reassess if it's working or not. So for the pieces mnemonic, this really stands for physical, intellectual, emotional, capabilities, environmental, and social aspects. And I'll break them down for you in detail. So when you deal with someone with the behaviors, you really want to touch upon all of these. And the reason is, and I really want to hammer this down, is you have to apply non-pharmacological treatments for all patients regardless. Even if you're going to start medications, you have to apply non-medication means. So physical, I think about delirium, disease, drugs, and disability. Intellectual, amnesia, apathy, aphasia, agnosia, all your A's basically. Emotional, about delusions, personality, adjustment, and mood disorders. Capabilities, their degree of functional aspects, what can they do and what can they not do. Environmental, is it, again, over understimulating? Is there too much noise, lighting? Did they just relocate from a different facility? And social, what's their network, life story, and social supports? Because that makes a big difference in your care. And let's take a case to showcase an example as to how this works. So a 75-year-old male who's wheelchair bound, that's a broken wheelchair, with diabetes and has stroke, so has vascular dementia, has falls and has depression, yells at all female nurses. That's a typo. So he yells at female nurses quite frequently and gets very anxious. Suspects he's being poisoned, so he doesn't eat anything in the unit or long-term care facility, is aphasic and does not speak. He's tearful all day and was started on amitriptyline a few weeks ago for depression. So the way I tackle this with the pieces mnemonic is, well, first of all, physically, I don't see any delirium that I could diagnose. The wheelchair is old. Intellectually, he has expressive aphasia, so he can understand but cannot speak. That makes a big difference in your care. Emotionally, has depressive and paranoid features. He can do some basic functions like feeding himself, but he cannot do his complex instrumental activities of daily living. Environmentally, it's very loud and extremely understimulating and very boring. And socially, only has one friend, and he used to be a farmer. The patient was a farmer. So what would you do if you apply pieces now? Well, first of all, I'd provide a new wheelchair, which is very easy to do. Educate so they can answer questions with yes or no, at least non-verbally, right? They can still communicate despite that limitation with expressive aphasia. Do not mention past trauma and only have male nurses visit him, right? So that's something you can do to change their dynamics and reduce said behaviors. Offer canned food instead of food they don't see in front of them being opened. This reduces the poisoning paranoia they have so that they can eat. Switch to, from TCAs to an SSRI. So again, reducing the cholinergic burden and reducing GERD syndromes that can occur as side effects from TCAs. Reduce sound in the environment and provide the Quran or any activities for him to be engaged in, given the understimulation of the environment. And then I'd say you can even ask their friend to visit or provide recordings of them, and maybe even safe farming tools. There's evidence showcasing that even if they don't know what those tools do anymore, having them around them can reduce their behaviors altogether. And if you really look at my assessment, only 1 point was in regards to medications. All others were non-pharmacological. And unfortunately, the status quo, as I said, is to default towards medications and throw antipsychotics so the problem goes away. And that usually does not work, you know, across the board. And I'll talk about that quite soon. So ways to deal with someone who has behaviors, at least in a clinical setting, there are verbal things you can do to reduce their behaviors or at least improve communication with them. So I would say talk slowly with a low frequency voice. As you know, presbyacusis, as you age, you lose the high frequency noises. So for female healthcare professionals, I'd say thicken or deepen your voice for them to hear you. Use one-step commands. Don't use complicated commands. Avoid arguing and accept their perceptions that are false. You don't have to insist on correcting them. Use yes or no or choice questions instead of having open-ended questions overall. And use their preferred name, and also repeat phrases and sentences until they understand you. For nonverbal means, really it's important to note that these are ways that they are communicating with you. Their behaviors, and I apologize for the comparison or analogy, but similar to children who can't communicate, right? They'd end up crying. They can't tell you they have pain or they can't tell you that they're hungry, so they cry. Similarly, with those who are demented, their behaviors are ways that they wish to communicate for their unmet needs. Recognize nonverbal cues for having these behaviors, eye movements, lifting of the mouth, tearfulness. And always make eye contact and give them enough time and listen actively, which can be very difficult, you know, in a very busy unit or ward, right? Other things you can do is you want to exaggerate your gestures and always have a delay in between asking or doing something and having a response to it. You really want to mention what you want to do before you do it. So for example, if I want to listen to their chest, I'd say, I'm going to listen to your chest now, show them the stethoscope, maybe even mimic the listening on their hand and then place it on their chest, relative to saying, I'm going to listen to your chest and at the same time put the stethoscope on their chest. Or not even ask and just do it. These sudden movements can seem very daunting to them. And also have 3 times the bubble space. So if you were to think about a normal conversation with someone, you want to increase that space between you and them. And as I said, increase the gestures you have with them overall. Avoid potential tools or equipment that could be at reach. So for example, your lanyard, if it's in front of you, dangling in front of them, they could grab it and pull you. So just some safety tips for you to have. And lastly, always have an exit strategy. You want to, for example, have the door behind you to exit in case you need to for an aggressive patient. Another tip is to have a table between you and them so that if they were to reach out to harm you, they can't. There's something in between you and them. And so far, I haven't been punched once, which is always a plus in your field. And overall, really, steps to summarize how to approach BPSD is, number 1, rule out delirium first, right? If it's a delirium, then it's an acute medical emergency. They need to go to the emerge to get dealt with. It's not their behaviors. Secondly, treat their basic needs. Treat their pain, constipation, urinary retention, their bowel movement concerns, their feeding, sleeping, drinking. And then, as I said, identify the BPSD and apply the DICE and pieces mnemonics I provided. And you can also send them to emergency or call the police if there are major safety concerns for aggression or harm to self or others. Now, in terms of medications and non-medication means, there's actually some evidence showcasing that music therapy, and I'm extrapolating from that the Quran, to reduce their behaviors. Obviously not in all of them. In some it can make it worse, but there's some evidence, at least somewhat moderate at best, to help reduce this. Also, in terms of snozzling rooms, so these are stimulation rooms that can help reduce said behaviors. Again, not in everyone, but certainly there is evidence for this. And aromatherapy as well. Lesser evidence, but it does exist. This is a fidget toy. Gen Zers know what fidget spinners are. So fidget toys can also help reduce overall boredom and reduce behaviors by fidgeting, by using these tools. So if you can imagine patients who are in units spending 95% of their day doing nothing, I'd be bored, let alone a demented patient with behaviors. So this can really help, and it's very cost effective to reduce their behaviors. And lastly, fine touch. Again, very good evidence to showcase there is helpfulness in touching their hands gently to reduce their agitated behavior. So again, even if you're going to do medications, you have to apply non-pharmacological means. Even if you do apply medications, you really want to think about SSRIs as your first line before antipsychotics. And unfortunately, as I said, the status quo is they prescribe antipsychotics as a knee-jerk reaction for all patients, which is unfortunate because antipsychotics do not even work in a good number of behaviors. So for example, wandering or yelling or perseveration, there's evidence that it does not work. So you're getting the side effects of those medications and none of the benefits. And if you were to attempt it, you want to do it and give it at the most lowest dose, lowest frequency as possible, trial for 3 months and then taper off by 25% until you can get off of them. And really you want to choose the antipsychotic based on side effect profile. Usually they're almost all the same in terms of efficacy. And this is an important slide I'd like to mention to my colleagues who are non-geriatricians as to what are good indications for antipsychotics. And really it's distressing psychoses, so not just psychoses in general. If they're hallucinating and seeing a dog or a man, but it's not distressing for them, usually it's for the family really, then I would argue against antipsychotics relative to them being very bothered by hallucinations. Then I'd say, yes, it's distressing, then prescribe them. Harm to self or others, a good reason. Resisting or removing life-saving equipment or lines. And if they're non-responsive to all other means that you've tried with their behaviors. So, in summary, these are 10 practical tips to provide to deal with behaviors and BPSD overall. Do not insist on correcting them, accept their perception of reality. Really, this is the first thing I share with families as a whole because it damages their relationships and you're going to get nowhere. Secondly, treat their basic needs. First, we talked about this. Rule out delirium, which is a medical emergency technically. Always do non-pharm treatments regardless of the case. Antipsychotics are not magical pills and should not be first line whatsoever. There's good evidence on this. Apply the dice and pieces mnemonic and approach and have the bedside manners I talked about to communicate with them more effectively. Manage family expectations. On almost all follow-ups I get with these patients, they repeat the same concerns and need reassurance. And it's an ugly disease where behaviors change with time. The disease progresses with time, which makes it even more tricky when you want to provide them with these management tips and approaches, non-medication and medication means, and some respond, some don't, some do it first, but then that changes with time. And unfortunately, the progression complicates it, and you won't know if it's helping or not until you remove the drug and see that it actually was. You really want to also balance the benefits with harms for the patient, even if it will help with some of their behaviors. If they can't tolerate the side effects and they have really poor quality of life, you don't want to pursue that route. Use their life story and be creative. So one thing I ask families here is what's their life story, what are their hobbies, what do they like? Provide that to them as much as possible. And then lastly, their goals of care. So documenting their will, documenting advance directives as much as possible, aligning with the values that they would have wanted, not what the family would have wanted, as much as possible. Just a quick resource I wish to share before ending my talk today is this is a website that I've designed over 3 years' time as a scholarly activity called Ageless Agenda. And it's a public health education website that's free. I have no conflict of interest to declare on this, both in English and in Arabic. That's free to use, as I said. And the point of it is it's very readable, grade 9 level of readability and onwards. And it's directed towards patients and their families to help support geriatric medicine with 23 topics. So hopefully it's beneficial to those interested. And with that, I wish to thank you for your time.